what I'm going to do is to lead you through the basic anatomy. I'm not going to get into well, there's a few complex parts here, but I'm going to stick with the basic anatomy and revise with you the anatomy of double outlet right ventricle. First of all, I'm going to start with a normal heart. You just saw the cast there of a normal heart. This is a normal adult heart, which we've dissected away to show you the outflow tract, in particular to show you the structure of the right ventricular outflow tract. And I just want to focus on this because the features of the normal right ventricular outflow tract are crucial in the understanding of double outlet right ventricle. So very briefly then, just to reiterate, looking here at the right ventricle, opened up in nice anatomic fashion, of course, so you don't see that as a surgeon. I don't see it quite as well as that. But here's the tricuspid valve, which we've opened up, and the anterosuperior leaflet, the septal leaflet, and the inferior leaflet just here. And you can see the trabeculations within the apex of the right ventricle, the coarse trabeculations within the right ventricle there. And then as we come towards the outflow tract and we move towards the pulmonary trunk, there are specific trabeculations and folds which we need to consider and we need to understand so that we can then understand complex cardiac malformations. We need to consider then the structure of the right ventricular outflow tract in the normal heart. So the first things we need to consider then, the landmarks that we need to look at are the bands of muscle which are attached to the right side of the ventricular septum, and in particular the septomarginal trabeculation, which in the normal heart is fused to the right side of the ventricular septum. It has a trunk, quite a wide trunk normally, which runs down towards the apex, and then at the apex it gives rise to a series of roots, if you like, which then run into the apex of the right ventricle, and also along the side here they turn into what's called the septoparietal trabeculations. But certainly at its root here, it usually gives rise to a large muscle bundle which crosses the cavity as we know that as the moderator band. More towards the pulmonary trunk and towards what we call the inner heart curvature here, this is the region of the membranous septum just here beneath the tricuspid valve. The limb then divides into two parts, and the structure of this limb, the Y-shaped structure of this limb, is crucial, as I say, to understanding double outlet right ventricle, because depending on the attachment of the structures, the outlet septum in particular, to this limb in double outlet right ventricle, the VSD will either open in subpulmonary or subaortic position. So let's just look at it in the normal heart first of all and focus in on this region. You'll see that there is a limb here running essentially upwards towards the pulmonary valve. The pulmonary valve is at the top of the screen there. You can see the leaflets of the pulmonary valve, which are supported by a completely muscular infundibulum in the normal heart. And there's a limb which runs up to the pulmonary valve from the septomarginal trabeculation almost directly vertically. And below that limb in the normal heart we'll find the first septal perforating artery. So it has a relationship to the perforating arteries, to the coronary arteries of the normal heart, and clearly you need to consider that also when we're looking at double outlet right ventricle. Now, the other limb points back towards the membranous septum, towards this region here. You can just about see the membranous septum here in this heart, and it's crossed by the tricuspid valve, dividing it into two components. But the inferior limb of the septomarginal trabeculation runs back towards the membranous septum and joins on it. And you'll see just coming from the inferior limb here, you usually see a small muscle bundle, which is the medial papillary muscle, or the muscle of Lancisi. And in the normal heart, if we draw a line between the membranous septum and the medial papillary muscle, then that's the line of the right bundle branch. That's the line of the conduction axis viewed from the right ventricle in the normal heart. And clearly, again, that's important in double outlet right ventricle because all of this region is malformed. Now, so we've seen the two limbs of the septomarginal trabeculation. then what is sitting in between those limbs? Well, there's a small crescent of tissue, which you can just about see here, which is hard to distinguish from the surrounding tissue. But I think in this heart, you can just about see a small sort of eye-shaped crescent of tissue, and that is the outlet septum in the normal heart. It's very difficult to distinguish, as I say, from the surrounding structures. But if I put a pin through that muscular region there, I'd go directly into the left side of the heart and into the left ventricular outflow tract there. So there's the aortic valve just above. So the outlet septum in the normal heart then sits, it is a fairly indistinct structure, and sits within the arms of the septum arterial trabeculation and is effectively fused to it and is parallel and forming part of the ventricular septum itself. So the outlet septum is in the same plane as the ventricular septum. And of course that changes completely in double outlet right ventricle. In double outlet right ventricle, as we'll see, the outlet septum is malaligned and becomes exclusively a right ventricular structure. And that allows both arteries to come from the right ventricle. So small little area there, the outlet septum. Perhaps the larger area of tissue here separating the tricuspid from the pulmonary valves is this region, and this is what we call the ventriculo-infundibular fold, or the two portions together, the outlet septum and the ventriculo-infundibular fold, have also been termed the supraventricular crest. But we can actually divide them into two portions, and this portion here is the ventriculo-infundibular fold, and it is a fold of tissue. So if you cut away this tissue in the normal heart or in double outlet, you'll actually go outside the heart, and more specifically, you'll come into the transverse sinus here, near and close to the origin of the right coronary artery. And in fact, there you can see the origin of the right coronary artery. The coronary artery has been cut away there. But if I perforated this region, you'll see I'll come into this fatty tissue, which is within the transverse sinus and close to the right coronary artery. So again, resection of that region is possible in certain circumstances, but you need to be sure that you're not going outside of the heart. So the two together, the outlet septum and the ventricular-infundibular fold, are clasped in the Y-shaped trabeculation, which is the septomarginal trabeculation. And then in the normal heart, as I say, to complete the picture, we need to consider the muscle bundles running along the anterior wall. You see there's a few of them in this particular specimen. These are the septoparietal trabeculations, and they become important because they become hypertrophied in tetralogy of Fallot. So hopefully that's all revision. That's fairly straightforward. That's the normal heart. Now let's look at double outlet right ventricle. And I think it's true to say that we can divide double outlet right ventricle into 5 types. The 5th type is probably so rare as you know is to be excluded really. So there are 4 main types, but if we're being anatomically correct, then there are 5 types of double outlet right ventricle. And I think it's fairly well accepted now that what we're talking about with double outlet right ventricle is a ventricular arterial connection. Does everyone agree with that? We're talking about the situation where both great arteries, it sounds common sense, but we're talking about the situation where both great arteries, or the majority of both great arteries, arise from the morphologic right ventricle. Because historically there have been problems with definition, as you know, and I'm not going to emphasize those, I'm not going to go over that ground, but I will mention one of them a little bit later on. So this is perhaps the simplest situation, and this is the rarest situation that you'll encounter, but clearly both of these great arteries, without doubt, come from the morphologic right ventricle. You can see that they are positioned pretty much side by side in this example. So the aorta is positioned to the left in this heart, and the pulmonary trunk is positioned towards the right. Here you can see the arch and the head and neck vessels branching from the aortic arch. So we have more of a side-by-side arrangement of the great arteries, which is a variable feature in double outlet. But I can be sure that this heart has double outlet right ventricle, because in this particular case, you'll see that both arteries are coming from this anterior ventricle, and there is no ventricular septal defect. So there's no debate really in this heart. There's no way that an artery can partly override the septum. This is the unusual situation with an intact ventricular septum with both great arteries coming from the right ventricle. And I don't know how many, I don't know how many people have seen an example of this in clinical practice at all. Has anyone come across this with an intact ventricular septum? I mean, the most usual situation that this occurs in, as in this heart, is in the setting of left heart hyperplasia. And you'll notice that the trabeculations in this right ventricle are slightly anomalous. Here you can see that large trunk, the septomarginal trabeculation, is separated from the ventricular septum. So it's standing almost free within the right ventricular cavity, and that's a sign that, or goes along with left ventricular hyperplasia. Start to get anomalies of the septomarginal trabeculation. And if I turn the heart around, you'll see that there is, in fact, a very small left ventricle as delineated by the coronary arteries, by the descending coronary arteries there. So the left ventricle certainly doesn't reach the apex of this heart. And if we looked into the left side, you'll see that there's complete atresia. If I can get the right side, here's the left atrium. You can see there's complete atresia of the mitral valve, so there's effectively an absent left AV connection. There's just a dimple there in the base of the left atrium, where we'd expect the mitral valve to be. So classical mitral atresia in association with double outlet right ventricle. Now you could, I think it's probably logical to assume that in this instance there probably was a ventricular septal defect at one point during development, and that it has closed up, but we can't prove that. But I think it's fairly logical to assume that that was the case, and therefore the intact ventricular septum developed as the sort of during fetal life, during the early part of fetal life. You'll notice that in this heart, both of the great arteries, the aorta and the pulmonary trunk, are supported by musculature, so muscular infundibulum there supporting both great arteries. And the outlet septum, which always separates one arterial valve from another, as this muscular structure just there, is, as I say, malaligned with respect to the ventricular septum and is now exclusively a right ventricular structure. So there's no doubt about that this is a right ventricular structure in this heart. So that's the rarest situation that you'll find. Really, we only need to consider the other four categories in double outlet right ventricle. So all we're defining really is the connection of the great arteries to the heart, and we're saying that both of them, majority of both arteries, arise from the morphologically right ventricle. Now, surgically, then there are other things that are more important on top of that, of course. And perhaps the most important one is the location of the ventricular septal defect and consequences for its location. Now, I've shown you an example without a VSD, but most of the hearts with double outlet right ventricle, 99.9%, will have a ventricular septal defect. It's not always related to a great artery, but there will be a VSD allowing blood to flow between one ventricle and the other. Now, first of all, the first type that I'm going to describe to you then is where the defect opens beneath the aortic valve, and this situation then is more frequently seen with the great arteries in side-by-side orientation, with the aorta slightly to the left, so very similar to the heart I showed you just a moment ago. And you can imagine if in that previous example, if this VSD had shut, we'd end up with an intact ventricular septum, and it would wall the aorta completely into the right ventricle. So usually in this situation with a subaortic VSD, the arteries are more parallel, or the aorta might be slightly behind the pulmonary trunk, but usually is to the left. to the right of the pulmonary trunk. We can get very rare situations when it's to the left. So majority of the time it's to the right side of the pulmonary trunk. And if I just point out the structures in this heart, you'll see that both arteries are coming from the right ventricle, first of all. Here is the medial papillary muscle. So we know that we're in the region of the membranous septum. The membranous septum, in fact, is just tucked behind that muscle there, a bit more inferiorly. And you'll notice that in this heart, there is a muscular posterior inferior rim to the ventricular septal defect. And why is that? Well, the reason that there's musculature separating the VSD from the conduction tissue in this heart is because the inferior limb of the septomarginal trabeculation that I showed you earlier, so here's the body of the septomarginal trabeculation, inferior limb and a superior limb. The inferior limb has fused to the fold of tissue which separates the tricuspid from the arterial valves. So in other words, to the ventricular and fundibular fold. The two fuse together, then we get protection of the conduction axis. Now, that's the first thing to note in this heart. So we have muscle protecting the conduction axis. The second thing to note in this heart, and the reason that the VSD is in subaortic position, is because of the location of the outlet septum. So you'll notice we've cut across the outlet septum in this heart, and you'll see there is a tissue plane which runs down here, so that there is in fact a subpulmonary infundibulum in this heart, supporting the leaflet of the pulmonary valve. So there's muscle here running down to this level. I can separate the arterial trunks down to this point. So if you resected, for instance, the outlet septum beyond that point, you would risk the valve attachments, and particularly the aortic valve. But you can see that there is a muscle component to the outlet septum which is hanging down within the right ventricle, is exclusively a right ventricular structure. And if we look at the location of that outlet septum, you'll see that it's attached not to the inferior limb, and it's certainly not sitting in its usual position here. It's in fact attached anteriorly, and it's attached to the anterior limb of the septomarginal trabeculation. So when the outlet septum is deviated or attached anteriorly in the setting of double outlet, the VSD will usually be in subaortic position. And here you can then see the outflow leading out to the pulmonary trunk, which is unobstructed in this particular case. So the outlet septum is sitting in the right ventricle, but is not deviated sufficiently to obstruct the pulmonary outflow tract. If we look at the left side of the heart, though, okay, here is the left ventricle. You'll see that on the left side of the heart we have the mitral valve running onto the aortic valve. So there is a mitral to aortic fibrous continuity, as we'd find in the normal heart, and yet the majority of the aortic valve, as I'm showing you from this side, is connected to the morphologic right ventricle. So we only have one infundibulum in this heart. We have one infundibulum below the pulmonary valve, and yet the connection is still double outlet. There is, in the States in particular, there is a definition of double outlet which requires there to be bilateral infundibulums. But as we say, we're all agreed that it's a problem of a connection, and the infundibular structure is variable. So then let's look at the logical progression when you have a subaortic ventricular septal defect, because if you're going to have anterior deviation of the outlet septum, then you're probably going to see a spectrum towards tetralogy of Fallot, because that's the characteristic of tetralogy of Fallot. In tetralogy of Fallot, we have two things mainly. We have anterior deviation of the outlet septum, so it's attached to the anterior limb of the septomarginal trabeculation, which is here. You can see the body, the septoparietal trabeculation is here, and its superior limb is running up here, and the outlet septum is attached to that. The second thing that you need is hypertrophy of the septoparietal trabeculations so that the outflow tract is narrowed. And if I open up this outflow tract, you'll see that there are 2 points of narrowing, in fact. There's the muscle here, which is producing a squeeze, And then built up on top of that now, if I just zoom in a little bit, you'll see there's a fibrous ridge. So there's now a distinct fibrous line here, subpulmonary fibrous ridge there, which is built up on top of this abnormal muscle. And then beyond that, we have the leaflets of the pulmonary valve. So undoubtedly, this is the anatomy of tetralogy of Fallot. If you look at any heart and you see this sort of structure, then you have tetralogy of Fallot. And of course, you have the VSD and the right ventricular hypertrophy as well. But this is the hallmark of tetralogy of Fallot. But in this heart, you'll see, if you look at the connection of the great arteries, you'll see that both the pulmonary trunk, which is anterior and to the left of the aorta this time, and the aorta, which is much larger, are connected to the morphologic right ventricle. Most of this aortic valve, certainly two whole leaflets here, are committed to this morphologic right ventricle. So we have double outlet right ventricle in association with tetralogy of Fallot. Now, in this, as I say, this tends to be the situation, sometimes will occur in the situation where the outlet septum is deviated and is attached anteriorly to the anterior limb, and that leaves the VSD in subaortic position. And in fact, in this heart, you'll see that the inferior limb of the septum artery speculation fails to meet the ventriculoinfundibular fold. So this is the fold of tissue separating the aortic and the tricuspid valve. There's some attachments of the tricuspid valve, in fact, here to the medial papillary muscle, but here also to the ventriculoinfundibular fold. So it's a fairly short structure in this heart. But if you look at the posterior inferior margin of the VSD, you'll see that it's in fact fibrous tissue. So this is the remnant of the membranous septum here. You can see it's thin, it's membranous, it's the remnant of the membranous septum. Just below that, we'd expect to find the conduction tissue. So the conduction axis is close to the VSD, but in fact is protected a little bit by this fibrous tissue. Whether you'd call that protection or not is another thing. But the reason that the membranous septum is exposed in this heart is because the inferior limb has failed to meet the ventriculoinfundibular fold and leaving fibrous tissue instead. So in most of the cases with tetralogy of Fallot, as you know, we have a perimembranous VSD, so as you're seeing here, fibrous floor to the VSD or fibrous posterior inferior rim, and that's the same situation in double outlet right ventricle with tetralogy of Fallot. Now in this heart, if I show you the other side, you'll see the left ventricular outflow tract, and you'll see how the way out from the left ventricle is effectively via the ventricular septal defect, which is here. So most of the aorta, as I say, is committed to the morphologic right ventricle. There's only perhaps one leaflet coming from this left ventricle. And the way out from the left ventricle then is via this interventricular communication and via the VSD. So most of the time, I guess if you're coming to repair this type of heart, plus or minus tetralogy of Fallot, you should be able to wall or tunnel the aorta into the left ventricle, and then you might repair the other lesions. But most of the time, if the subaortic ventricular septal defect, providing there's adequate room here to put a tunnel, to put a baffle in here to wall the aorta into the left ventricle, to put a baffle in here, then you could repair it in that way. Now, clearly, you need to make sure that there isn't subpulmonary obstruction, and there is in this heart. And sometimes if the baffle or the distance is not sufficient, then you'll end up with obstruction between the right ventricle and the pulmonary trunk. So first type really is subaortic ventricular septal defect, which can be, as we see, associated with tetralogy of Fallot. So the conduction axis, so this is as the anatomist would see it. So I'm showing you with the head up here and the feet down here. This is the oval fossa, and here's the coronary sinus. So if we pull on the muscle just above the coronary sinus, as I'm showing it to you here. This is the tendon of Todero, which is running up here to the membranous septum, or the remnant of the membranous septum. That's the left arm of the triangle of Koch. The right arm is the hinge line of the tricuspid valve, and the coronary sinus is the base. So that's the triangle. We know the AV node then should be positioned at the apex of the triangle of Koch in here. And that's providing, of course, that there is good alignment between the ventricular septum and the atrial septum. So in other words, a VSD, not a extensive VSD opening to the inlet. So then from that point, from the AV node, which I've pointed out here, the conduction axis will run through here, penetrate the fibrous tissue, and if I turn it around, then you'll see that it will be running just here. I'll just zoom in a bit. So we'd expect it to be emerging in this region here between the remnant of the membranous septum here and the ventricular septum. And then it'll branch into the left bundle branch down here on the left side of the septum. And then the right bundle branch will head back, sometimes through the septum, towards the medial papillary muscle at this point. So if you draw a line, as I say, between the apex of the triangle of Koch, which was here, and the medial papillary muscle, which is there, then that's the axis of the conduction tissue, effectively, running along there. The next group then that we need to look at, I guess, is subpulmonary ventricular septal defect. That's the next most important group. And for that, I thought I'd show you this specimen first of all, to show you how it can be quite tricky and how there is the overlap between double outlet right ventricle with subpulmonary VSD and transposition. So in other words, discordant ventricular arterial connections. So what I've done here is taken a section across the outflow tracts in a heart in which there are parallel great arteries, and here's the aorta positioned slightly anterior to the pulmonary trunk, but certainly they're side by side. And here you see the outlet septum hanging down into the ventricular mass. This is the right ventricle, this is the left ventricle. And you can see that as I hold the heart in this position, and if we follow the ventricular septum upwards and look where it cuts the arterial valves, and if I hold it in this position, you'll see that pretty much this is transposition. So here the aorta is coming from the right ventricle, the pulmonary trunk from the left ventricle. There's a bit of subpulmonary stenosis there, I guess. But if I move the pulmonary trunk slightly more anteriorly so that it's overriding the crest of the septum, now we have the situation where both great arteries are coming from the right ventricle. So there's a spectrum, depending on the override, of the degree of override of the pulmonary valve when there's a defect in subpulmonary position between transposition and double outlet right ventricle. That's in simplistic terms, effectively. Now in this situation, let's just show you a heart then. Oops. Let's start off by showing you a heart with subpulmonary VSD, a simplified one, a simpler one rather. Because you'll see that the VSD, this is a heart with a subpulmonary VSD and double outlet right ventricle. So let me just show you the great arteries first of all to orientate you. So we've made several cuts in this heart. As I say, they're not shown in surgical format really at all. But you'll notice that the arteries are side by side or parallel to each other, but the aorta is slightly more anterior this time than the pulmonary trunk. So it's effectively in the position that you find in transposition. And the aorta is slightly smaller than the pulmonary trunk, which is something we'll come on to in a minute. But certainly they're in parallel arrangement, not normally spiraling as you'd find in the normal heart. So I'll show you the right ventricle, and then beautifully in this heart you'll see the septomarginal trabeculation, this all-important marker within the right ventricle. And look at the VSD, it's still sitting within the arms of the septomarginal trabeculation. So with respect to this muscle bundle, it's still in the same position as before, as the heart that I showed you before. So just to reiterate, here's the septomarginal trabeculation, here's the body. You can clearly see the anterior limb, the superior limb, I should say, because this is the superior portion of the heart, not anterior. So the superior limb's heading up towards the pulmonary valve. That will overlay the first septal perforating artery as in the normal heart. And then the inferior limb, as you see there, is heading back towards the region of the membranous septum. And I can't remember actually in this heart, no, whether the defect is perimembranous or not, but it's not there clearly. You need to peel back the tricuspid valve to see whether there's muscle separating the VSD from the membranous septum. The membranous septum is sitting back here in this region, so this is where the conduction axis will come through. And if I open it up, you'll see that here is the triangle of Koch, so coronary sinus in its base. This is the tendon of Todaro. Where that hole is, effectively, is where the AV node will be, just a bit more within the right atrium there. And then the conduction axis will run and penetrate through the fibrous tissue, through the fibrous interlacing tissue, the membranous septum, and then branch out into the right and left bundle branches. So the right bundle branch then would head towards the medial papillary muscle, which is here, and from the AV node, and therefore would be in this region. And you can see that there's a small region of muscle there separating the VSD from the conduction tissue, but not a lot. There's a small degree of protection in this heart. So we have a muscular VSD, which is more frequent in this setting, the subpulmonary VSD. We have a muscular VSD rather than perimembranous one. But as I say, it seems to be sitting within the arms of the septum arterioventricular lesion. It is, in fact, sitting in the same position as the previous heart that I showed you. So why then is the pulmonary trunk overriding the VSD? Well, the key is in the location of the outlet septum, because here, if I show you the other outlet, here is the aortic outlet. You'll see it's much smaller than the pulmonary outflow tract. And here, separating the two arterial valves, so separating the aortic valve from the pulmonary valve, is the muscular outlet septum. Quite an obvious structure, quite a prominent structure in this heart. You can see it's separating the two. But it certainly isn't attached to the anterior limb of the outlet septum. And instead, you'll see it's deviated backwards and in fact is attached to that fold of tissue that I described to you first of all, the ventriculo-infundibular fold. So here's the outlet septum. You can see it's attached to this muscle fold here, which separates the aortic from the tricuspid valve. So if I put my probe through there, in fact I put a needle through there, you'll see that I come outside the heart somewhere there. I'm actually coming right onto the right coronary artery, so I'm going to move it slightly. So there, I'm coming outside the heart. I'm actually coming into the transverse sinus here. So this is the right atrium, this is the pulmonary trunk, and this is the aorta. I'm coming into the fatty tissue within the transverse sinus, as I say, right adjacent to the right coronary artery. So that's a fold of tissue, the inner heart curvature, and the outlet septum is attached to that fold rather than to the septum arterioventriculation. What that means is, because the outlet septum is deviated posteriorly, the defect effectively opens beneath the pulmonary valve. To cords. It's very variable, but certainly in this case, yeah, you've got, I mean, from experience, you probably know more about it than I, but it's a particular issue, isn't it, when you've got cords attached to the outlet septum. I don't know what the frequency is, but certainly you see it in a lot of specimens. You see cords from the tricuspid valve here attaching to the outlet septum. And that, of course, can clearly affect the repair. So outlet septum deviated, attached to the ventricular fold. We have subpulmonary defect. It's related, as we say, more to transposition. And I guess it's in the absence of severe subaortic obstruction, then you might want to patch the defect into so the pulmonary trunk is coming from the left ventricle, and then do a switch. But of course that depends on the associated lesions, which is what I'm going to move on to now. But that's one option, certainly. Now, if you wanted to enlarge the ventricular septal defect, we've seen that you can resect the ventricular fold, but you risk going outside the heart, so you can take away some of that tissue. Clearly, you wouldn't want to take away much tissue here inferiorly, because the conduction axis, as I've shown you, just below that. You could take away part of the anterior limb, the superior limb here, but you have to be careful of the septal perforating artery, which is just behind. The body of the outlet septum is safe. You can get blood tracking up onto the conduction tissue through incisions into that. But the outlet septum itself is a safe structure, though it would be relatively unimportant in this setting. So there are some regions which you can resect to make the VSD bigger. Now, with the outlet septum deviated and attached to the ventricular and fundibular fold, then the tendency is for there to be subaortic rather than subpulmonary obstruction, and you saw that in this heart when I closed it around. So you can see that there's a fairly narrow way out there into the aorta. The aorta is supported by a complete muscular infundibulum this time. So we have a muscular infundibulum here. On the pulmonary side, let's have a look at the left-hand aspect. You'll see that there's in fact fibrous continuity. Well, it's debatable, but I think there's mainly fibrous continuity there between the leaflets of the pulmonary valve and the mitral valve. There's perhaps a little bit of muscle just down there, but mainly that's fibrous continuity. So we have a subaortic but not a subpulmonary infundibulum, but certainly both of the arteries come from the right ventricle. Here's the pulmonary trunk, say overriding. Here's the aorta. And there's subaortic stenosis. So the tendency is with the subpulmonary VSD for the outlet septum to be deviated and if it's going to do anything, will obstruct the subaortic outflow tract. And if we follow this around, perhaps there's not significant obstruction in this case. I would say there's not significant narrowing of the aortic arch in this particular instance, but certainly there's a tendency here for there to be some subaortic obstruction. I'll show you another heart in just a minute with more obstruction. The other thing that you need to consider, I guess, is the coronary artery anatomy, because in this situation where you have a subpulmonary VSD, the spectrum towards transposition, then we're going to end up with more anomalies of the coronary arteries. And certainly when the arteries are positioned side by side to one another, you can see coronary anomalies more frequently. In fact, you can see that this coronary artery here looks a little bit abnormal. It's coming away from the wall a little bit abnormally there. That's the LAD, and here's the circumflex, which has just been cut away there. There's the remainder of it. You see the circumflex is running around the front of the pulmonary trunk. Here's the LAD running parallel to the septum. But when we look inside this heart, you might expect this coronary artery to enter the sinus, the right-hand sinus facing the pulmonary trunk. So this sinus just here is where it appears to be heading towards. But in fact, it's crossing through the wall. So it's running through the wall of the aorta. You can see it enters the wall here, then runs within the wall a short distance, and then comes into the same sinus as the right coronary artery. So both coronaries are coming into the same sinus. So this is an intramural course of the left coronary artery in association with double outlet right ventricle. So you need to be, well, something to consider anyway when you have this arrangement, subpulmonary VSD. The next group that we need to consider then is that with a doubly committed and juxta-arterial defect. So we have the VSD, once again, is in the same position as before. So sitting in the arms of the septomarginal trabeculation. You can't see it so well in this particular heart, but this is the Y of the septomarginal trabeculation just here, and there's a muscular posterior inferior rim in this heart. We have both great arteries here and here coming from the right ventricle. Hopefully you agree with that. The aorta is sitting in this example behind the pulmonary trunk, although they're more parallel than normal. So it's sitting behind the pulmonary trunk, perhaps a little bit more to the right than normal. But what defines this heart and distinguishes it from the previous examples I've shown you is that there is virtual absence of the outlet septum. So the outlet septum itself is only represented by this fibrous raphe, and sometimes it's completely absent. You'll see another example in a minute. So there's no outlet septum at all. So it's not attached either anteriorly or inferiorly, really. There's just a fibrous ridge here separating the leaflets of the pulmonary and the aortic valve. So the defect is what we call doubly committed and juxta-arterial. And effectively what this means is that both great arteries are potentially looking into both ventricles. But in this example, we see double outlet right ventricle. Now, in this heart, the raphe is deviated a bit posteriorly, so there's subaortic obstruction, but it can be deviated superiorly. So this is an important subgroup. It's a different group in terms of repair, I guess, because of the lack of an infundibular structure and lack of support for the valvar leaflets, the arterial valvar leaflets. And then we can see, this is another example of the same thing. Again, both great arteries, the majority of both great arteries coming from the right ventricle. You can see the septomarginal trabeculation much better in this heart. Here's the Y shape there, with the superior limb pointing towards the pulmonary valve, inferior limb towards the membranous septum, and you see that it's